Hello, everyone. Welcome back again to our panels at the 4th International Symposium of Complications in Implant Dentistry. I hope that the program was beneficial for all of you till now, and I'm so grateful and happy to introduce our next speaker, a dear friend. Dr. Ehab Rashed is here with us at the 4th International Symposium. Hello, Ehab, and welcome to the virtual symposium this year.
Hi, Omid. Good to have you, and thank you for inviting me over here.
It's our pleasure. I have to say that Dr. Ehab always supported us and supported this event, and from the very first year, he was always with us, and I really thank him for that. And this year, he will have a very hot topic to present, and with different aspects. So the main topic is bone defect management, but he will go through very, very late innovations in the field and will present you with beautiful, beautiful cases. I'm pretty sure you will enjoy every second of it, as I do. So before we start the presentation, I will have Dr. Ehab's CV for all of you, and then we straightly go to the presentation part. Dr. Ehab Rashed is an emeriti dental surgeon with over 26 years of experience in dentistry. He obtained his bachelor's in oral surgery and dental medicine from Cairo University. He is holding diplomate of oral implantology from Freiburg University, Germany, and master in science of oral medicine and implantology from Münster University in Germany. He joined the main UAE government dental hospital in 1991 as a general practitioner for 5 years, started his private practice in 1996, and he's a member of the American Academy of Implant Dentistry. He's the only emeriti dental surgeon who is holding the diplomate of ICOI, diplomate of DGOI, GBOI, German Board of Oral Implantology. He has been placing dental implants along with bone grafting and soft tissue reconstruction to replace missing teeth since 1998. And he is one of the pioneers in aesthetic dentistry in Dubai, and has been involved in aesthetic and corrective treatment since 1997. He's a dental XP expert, and also he has a very beautiful, well-organized clinic in Dubai. So if you guys go to Dubai, don't miss the chance to see his great educational center clinic. So Ehab, we are very again happy to have you at this symposium this year, and we are ready for your amazing presentation. At the end, we will have a little discussion on the topic together.
Thank you, Omid, for this nice introduction. I hope you will enjoy you and the attendance the lecture. And I wish everyone to end up this COVID-19 issue peacefully, and hopefully we go back to normal life as before. And we'll have a real communication with live seminars. Thank you very much. I believe now we are on, and everyone can see the screen now, I believe. Yeah. I'm gonna start just with my introduction to this lecture, that we'll be talking about bone defect and how the bone defect can be managed. But I'm not gonna bore you with the theoretical part a lot, so I will try to be minimum in theoretical, because I'm sure that anyone can just go in the textbook and read the things. But I want to show you how to implement these basics in the real clinical cases that we face every day. And we talk today about this bone defect management, which is usually a problem that happened in the bone. Just to let everyone understand what the meaning of bone defect, let's just look at the definition of the bone defect. Actually, it's a meaning that when the bone is missing in part of the jaw, and this bone has to be restored, because the bone will eventually support the soft tissue, and then the soft tissue will also do the real success or finalized success of the bone at the site. So if we have a bone defect at any area in the jaw, we have to understand how to manage this bone defect. Usually, to manage the bone defect, we will do something called the GBR. To just summarize quickly what the meaning of the GBR, it's a process that we guide the bone to grow at the site. So if you have a defect at the site and some missing bone due to any kind of pathology or any extraction or a trauma, we have to understand that this bone has to be rebuilt again. And that in order to restore the function and restore the aesthetic, and also restore the site for the prosthetic part to be performed in a correct way. So if you look just briefly at the indication of these bone defect management, we have to build the bone around implant to place implant at extraction site, or we can do socket preservation if we need to do an implant later on in the future, or also if we need to restore the bone due to extraction or due to cyst removal or removal of any pathology at the site. Also, repairing the bone at the site after wound healing and after implant placement. So this is just the 4 basic information that we need to know when we have to do the GBR. Just to understand how the bone grow, we need a growth factor at the site. These growth factors that usually comes from the cells that are available at the site, or also come from the blood vessels and bloodstream that come to the site. And we need some vital cells, which we call them osteogenic cells. And these osteogenic cells will also differentiate into bone cells to form the bone. And we need to support these cells with something called the scaffold, or some kind of material that will hold the cells at the site, because we know that cells cannot grow in just a space. If we allow all these things to accumulate together and give them time to heal, we will create what we call it the bone regeneration. As you can see at this site here, that you can build from a defect at the first page at the top here, and then you can look down here at the bottom of the picture. You can see that we created this defect in a way that restored that we can place our implant in the correct position and we can proceed with the treatment. So this is just the idea of how we do this. And if we look at the type of bone cells, we have to understand what bone cells do we have, and also what material that we can use at the site. We understand there's something called the osteoinductive and osteoinductive. The osteoinductive cells or the particles that they will help the bone to really grow at the site. But the osteoinductive usually come from the natural cells that we use, or we can use some kind of cell that coming from a human that goes into the site and will perform or stimulate the actual cells to proliferate and perform a better kind of regeneration to create a real bone at the site. The osteoconductive, it's the material that we use at the site. This osteoconductive, they only work as a conductor just to let the cells transport from a place to another. So if you have a defect at the side or a defect at the center, we need the cells to come from the borders to the center, to that area, to perform the growth, to proliferate or assist the cells to grow at the sites. We also have the cells that come from the blood, which is undifferentiated mesenchymal cells that usually will differentiate into osteoblast and osteoclast and monocytes, and also will create the growth at the site. This is will leads to the actual bone growth at the site. This is just a very brief kind of introduction to know what we need at the site as vital cells, and what we need at the site as a scaffold at the same time. Something also we have to understand when you do GBR, we have to create what we call it the barrier membrane. And the barrier membrane, it's a membrane that we use at the site to support the grafted area, because this membrane has to protect the bone particles, have to protect the bone cells, because we know that this is a newly grown bone cells. They need to be protected from the invasion of the soft tissue at the site. And these bone cells, in order to grow, they need to have kind of protection, need to have kind of stability, and also it will need kind of permission to let the blood supply enter that site. So we need a kind of a barrier membrane that will allow all these function to happen. I will guide you through all the kind of techniques that we will see, and then we'll go and understand how this works. So we understand from the literature showing us that usually if we have any kind of a defect at the area around implant or around any tissue, we need to understand that we need about 2 millimeter or more than 2 millimeter bone at the buccal side, and this will stabilize the area. So if we have an implant or area that we grafted the area and the graft leads to a result that less than 2 millimeter, we understand that this area can have a defect later on in the future or have a kind of complication in the future. So we have to always increase our bone grafting material or technique to allow us to have more than 2 millimeter on the buccal side. And we also understand that we have a stability of the graft, and we also need to have enough blood supply at the site. And if you do these things all, you will create what we call it a good environment for the bone cells to grow. And the bone cells will always grow at the site if you allow all the cells to have this kind of parameter that I'm discussing with you now. If you look at this case here, we see that we place the implant. Implant is totally stable at the first picture here, and you can see the implant is exposed on the buccal side. And I started to perforate the area, as you can see here, just to decorticate the site, because I want to get the blood to flow into that area. If you look at the bone around the implant site, you see that there's no bleeding in this bone. So I understand that if I graft the site, I need some blood vessels to come to this area. We need vascularization at the site. So we start to create this kind of holes at the cortical bone to allow the a blood vessel to penetrate through them. And then you can see that I placed some artificial, vital bone cells grafted from the site as well, and I place it in a direct contact with the implant. And this is, as you can see in the slide, it says it's an osteoinductive particles, because these are vital bone cells. These bone cells will initiate the real growth of the cells. So I cannot place some artificial bone particles on the implant, because implant is a dead structure, it's a metal structure, and if I place also a bovine particles onto the surface, it will not have any kind of vital cells to grow. And then at the end of the slide, you can see that I placed my titanium mesh to cover the area. And this titanium mesh, if you look at the mesh design, you can see that it's nicely enclosing the site to circulate all the particles, so the particles does not scatter. If you look around, you can see that all the particles are sticking together. It's not moving around. And you can see that these kind of mesh or a membrane is kind of protecting the site, making a shape for the bone to grow in this site. If I don't have this kind of protection for these vital cells, the soft tissue, once I close the flap, it will compress the site, and the bone cells will not have a space to grow, so eventually they will dissolve and they will not grow. This is some basic things that we have to understand, that if we just place our bone particles and place our xenograft or any material that we place and just not protect the area, the soft tissue will invade the site and we will lose all our graft. This is just the basics of the doing a GPR. So let's understand what's the GPR indicated for. It's indicated for increasing the width and the height of the bone. So if we have a site that have a short bone, you can do a vertical augmentation, or if we have a thin ridge, you can do a horizontal augmentation to increase the width of the bone. If we look at the places where we can get the bone, we can get the bone from the donor. As you can see, this is, we call it the autogenous bone cells, which is the gold standards in any kind of bone graft. You can get it from different part of the jaw. You can see the symphysis mentae, the retromolar area, and the tuberosity. And actually, my best place that I get these bone particles usually from the retromolar area and the tuberosity, because they have a very well vasculated blood area, and the cells in this area are quite active, so it's even less traumatizing for the patient when you take the bone from that side. Also, we use something called the bone substitute and the bioactive stimulant. Like we take allograft from a human, or you can take a xenograft from animal, or also you can take synthetic bone that is manufactured in a lab, which is like minerals that like hydroxyapatite, or also like calcium phosphate. So this is the basics that we have to understand, that when we graft a site, we might use one of these material, but we have to understand why we use material in every different site based on the demand that we need, based also on the things that we have at the site. If we have enough blood supply, if we have blood that comes to the site, if we have enough vital cells at the site. So every material has an indication of use, and we have to understand the indication of each material, because we cannot use just one substance for every defect, and we expect to have always the same results. The one more thing that I always lose a lot now was something called the sticky bone that was created by Professor Son. He will be also lecturing in the symposium later on. You will see he have lots of nice cases. He came up with this idea that if you mix the bone substitute and infiltrate it with the growth factor that you take from the patient, and after centrifuging it, you mix it together, you perform a putty kind of consistency of bone that you can place at the site. And the idea behind this, that you create a bulk of material that it does not move around and does not scatter. It sits in one place, which is also leads to stabilization of the graft. And also it will be filled with growth factor that will initiate to the undifferentiated mesenchymal cells to come to the site, will also invite the different cells to come to the site to start performing. And we will later on see how we use this kind of things. There is also something important that I want to discuss with you, which is called the essential factors to have a successful GBR. Many of our colleagues follow an instruction that they see in lectures and seminars, and then they come back at the site after a few months and they see that they don't have any kind of a bone at the site, and they wonder why this is happening. And this is because if we do a graft at any kind of material or at any site, we have to implement these rules. I call it the 1+4S rules. Let's look at these rules to understand. The first thing is the primary wound closure. If we graft a site that we cannot close the site at the end of the graft, we definitely gonna lose the graft at that site. So this is the first thing that you have to understand. You have to be able to close the site after grafting. This is a crucial thing. And then the second thing that we have to have stability at the site. The stability is in the matter of, as a matter of understanding, is you have to make sure that your implant is stable when you place the implant. If you want to graft around implant, it has to be totally stable without any micro motion. Also, we have to make sure that the graft itself is very, very stable and it's not moving, that if you touch the graft, the patient go home and pull the mouth and lip to see and start touching the area. If the cells are not stabilized at the site and start moving around and it will not be sticking to that site, we're gonna lose these cells gradually. And also the supply of the blood that has to be sufficient at the site. So when we graft any site and we look that this site doesn't have enough blood flowing into the site, we will understand that this site will not be successful if we just leave it like this. So we have to understand where we're going to get the blood to flow into the site. And if there is no blood at the site, that's why in some cases you see me doing decortication, because I want to see the blood coming into the site. Sometimes when I see enough blood circulation and just enough blood vessels at the site, I don't need to do this kind of decortication, and I just proceed with my technique. And the last also important point is the space. So when we place any kind of bone graft, we have to create a space for these graft to grow. If we don't have a space for the graft, the soft tissue will always invade at the site. So our main target when we do this space maintenance is to place any kind of a membrane that will support the space and keep it for the bone cells to grow, because the bone cells doesn't have the power to push the soft tissue to come to that site and gradually grow after pushing the soft tissue. That's why if we leave the soft tissue compressing the site, it will not have any kind of result in GBR after we finish. So I'm gonna go through a quick tips or show you how to do tension-free closure in order to have a primary wound closure at the end. We can see here that I have a number 1 on the blade, this first blade that I usually use. And this blade, I use it to do what we call the crystal incision at the site. If you want to do crystal incision at the site, you use a very sharp blade. As you can see, I use usually 15C blade. And then once the incision is done, it has to be in direct contact with the bone. So the blade has to be done in a way that when you touch the blade should be in a direct touch with the bone. We shouldn't have any kind of space. And then we're going to do something called the vertical incision. These vertical incision, as you can see, they are stretched to the wider base, because again, I need enough base at the bottom of the image here, because I need more blood supply to come to the side. So we don't make these incision parallel, we make them more to the extended to the external side. And then these two vertical incision must go through the mucogingival junction. We cannot just do it in the keratinized tissue and stop. You see, it has to go farther, and we have to pass the mucogingival junction. And then we get the second blade now, and we'll do the periosteal incision. And you can see the periosteal incision has an extension more than the more than the crystal incision. So this is something very important, that once you do the periosteum incision at the beginning and not at the end of the grafting, and then you have to extend it beyond the vertical incision, as you can see, and it has to be longer than the crystal incision. And then after doing that, we can start placing our bone graft and proceed with the case. If you look at different techniques that been used and different materials, but they all have the same idea. This is a case by a colleague of mine, Dr. Peter Amin, and you can see that he used a kind of a reinforced PTF membrane, and you can see that he created all the parameters that I discussed about. There was a big defect at the site here, and then he placed these kind of membrane that will allow the cells to grow and protect the site and create the space, and he stabilized the graft. And you can see at the end he created a nice a bony ridge that can support an implant in the correct position, as you can see. Another technique also is used is, this is a case by a colleague, Dr. Ehab Musa from US as well. And you see he used the same kind of Curi technique, but he implemented the same parameters. I'm showing you these different techniques because you can see that every technique that been used for the bone grafting, they all have the same goal. They have to create a space. As you can see here, he's creating the space and putting these kind of Curi blocks at the external border, because you want to maintain the space for the bone cells to grow here. You can see that he will allow the bone particles to be inside here, and he filled the gap with autogenous bone particles, which is an osteoinductive cells. And then when you come back to the site, you can see how much bone that he created at the site. And also the same idea and the kind of the parameter that I was discussing. And if you see, this is a case that we'll be discussing later on. You also use a titanium mesh in this case, and you can see also the result is starting from a big defect on the top here, ending up with this kind of bone regeneration. So my point is that I want to show you that every kind of bone graft technique will lead to the same result, because we all aiming to the same essential steps: the stability of the bone particles, creating a space, creating a blood to circulate at the site, and also if you place your implant, the implant will be placed in a way that it's correctly placed with a good stability. So if we look at any case that we have in any part of the oral cavity, either this is a lower incisor, you can see this is a mandible, you see how the case started and how it's finished at the end. And also any case that comes also in a maxilla, for example, this is a case in a maxilla. Also, you can see how the case started with a big defect here on the buccal side, and then you can see how the defect was restored in the same way, and then the implant is placed in a correct position, and then you end up having a crown in a good position that you can restore it in a proper way. I will discuss with you also some important tips and tricks that I like to give you some kind of hints about it, how to achieve the proper kind of closure and proper GPR. We see that the releasing incision should overextend beyond the vertical incision. This is something that I mentioned earlier in the drawing. Also, we use a new blade, which is 15C, when you do the periosteal incision. So we don't use the same blade again and again, because one, the blade is used once is very blunt and it doesn't cut. And we see we make always the releasing incision before we placing the bone graft, because I've seen that some colleagues place the bone graft and then start doing the releasing incision, and that will lead to lots of bleeding and hematoma at the site that will also interfere with the bone regeneration. And you see the length of the pre-osteoincision flap will always be longer than the crystal. And then also we see that the vertical reaching flap must extend beyond the mucogingival junction. And also, when we release our lingual flap should be always longer than the buccal flap. This is if you do a graft at the posterior mandible, we have to make sure that the lingual flap will extend longer than the buccal flap. And we can see also that the sharp dissection always done to the buccal flap. So we always do a very sharp section with the buccal flap. We use blade for that. But with the lingual flap, we do something called the plant dissection, that we should not use any sharp instrument on the lingual side, because we don't want to injure any vital tissue that's sitting around the lingual side. And also something very important, that once you make a flap, before you graft the flap, you have to make sure that this buccal flap is 10 millimeter longer than the lingual flap. So I mean by, if we do a releasing flap in this here, before I start my graft, this flap should overcome the other side, and it should cover by 10 millimeter. I make sure that this will be enough when I place my graft. And then after you graft the site, you should have about 2 millimeter, as you can see here, 2 millimeter overlap after placing the graft. So before we place the graft, we should have about 10 millimeter kind of overlapping. And then once you place the graft, it should be about 2 to 3 millimeter. And also we have to use a stabilizing suture, which is, I usually use the horizontal matrix suture, just to stabilize the graft, to allow the site to be stable, and to stabilize, the flap, so the flap, it does not move with the muscle movement. And also one more thing, that we have to use the everted suture or interrupted suture to close the area at the end, or we can use the continuous looking suture to make sure that the site is totally closed and there is no kind of gaps that will lead to leaking of the bacteria to that site. So now we have to look how we release the lingual flap. This is something very important that I want to show you, how to release your lingual flap here. You can see we usually make an incision on the crystal area from the top, as you can see here. We do this normally, and then we go gradually in direct contact with the bone till we reach the mylohyoid muscle, as you can see here. Once you reach the mylohyoid muscle here, now we have to do another thing, which is the plant dissection. So basically we have to brush this area here. You can use any plant instrument, and then once this plant instrument is used, you can actually release the muscle fibers gradually. And if you look here, you can extend to 10 to 15 millimeter, and you have a big amount of release at that side. This is something very important, and you have to be well experienced to do this, and you have to be trained to do it properly. So if you look at the case here, this is how a case was done with this releasing of the lingual flap, and you can see the start. We had a big defect here, and look how much we created bone here and soft tissue around the area, and the area became very stable. You can look to this video to summarize quickly what I was discussing with you. So if you want to look here at this kind of case here, this is a case that came to the clinic, and the patient were required to have an implant in that area. You can see that I decide to place my implant because I have a good amount of bone at the correct direction, at the correct site, that I can place my implant in the exact site that I want it to be. And once I place my implant in that area, I understand that these kind of defect on the buccal side has to be restored. So I have to address this here. And this is how I go with it. You can see that everything is covered with bone particles, that usually I use a mix of autogenous bone. I mix it with a bovine bone, and mix it all together with the plasma. And then once this is all stabilized at the site, I create the space by using this rigid membrane. As you can see in this picture here, you have a rigid membrane here, and also I have the titanium mesh to cover the area to maintain the space. And then if you look at the case after we achieve the healing, look at the amount of bone and soft tissue that you created at the site. So I understand that this site is nicely healed, and the bone is enough to have support for the soft tissue, and I can load my case in that time. Also, something else as well, if you see here this picture also of a case that I have a big defect on the buccal side, as you can see here, a big amount of bone missing. I have to graft all the site here. I have to recreate the contour again of the site. And if you can see that I implemented the same parameters, implant is placed in a proper 3D dimension, and then the site is grafted with osteoinductive and osteoconductive bone particles and vital bone cells. I stabilize. You see the blood coming to the site from everywhere, so I don't need to decorticate. And then if you look at the healing of this case after just 4 months, you look at the difference at the image between the big defect from the top here to a very good contour to the lower picture. So this is a picture of the sticky bone that I use a lot. You can see that you can increase the height of the bone by making it more sticky, and you can see that you can shape it to the way that you want. You can make it into a circle or a big block or whatever you like to do. And the nice thing that you can see the bone particles embedded on the plasma, and it's not moving around. And these matrix that holding the bone particles is full of growth factors. So I know that this is a very a strong kind of boost to the site, and it will allow the bone cell to grow in a very good radical way. So we're gonna move on and see factor that can affect the site as well. We have to understand this. Why, if we graft at site, the site will have a deficiency later on if you come. If you see here, it's showing us the few cause of the failure of the site. If you have a smoking patient, because you know smoking that will interrupt the healing because of the vascularization and the also toxicity and the oxidation. And also we see that if there is infection at the site, that will might manipulate the pH at the site. If you have also cholesterol on a higher content, it will also lead to this kind of failure. Also, if you have a blood pressure that on a high kind of level, it can also increase the failure rate, and also inflammation at the site and the vitamin D deficiency that's been shown now in the many studies, that when you have vitamin D deficiency, that can interfere with the bone formation and that leads to failure at the site. This is some material that I use when I graft the site. Here you can see that the first one here is the bone scraper, that you usually use it once and you scrub the area and you collect, you see, you collect a big amount of vital bone cells here. And also something I use a lot also is the bone collector here that comes with a cylinder like this, and this cylinder can be either a plastic here or rubber, as you can see here, or a metal cylinder, as you can see here. And you can collect the bone once you reduce the speed of the handpiece. This is fixed on the handpiece, and you just gradually rotate it with the handpiece on a very low speed, like 200 RPM, without any irrigation, and you can create a big amount of bone, as you can see here. I usually, I said to you earlier in the lecture that I like to usually take my bone cells from the extended oblique ridge. You can see here how the area is used by this kind of bone collector that I use a lot. This is, I discussed with you. You can see that it doesn't go that much deep. It's only 2 millimeters, and this area is a quite safe area. And you can see the site after taking the bone. We did not create any kind of a defect. It's only 2 millimeters, so it's considered to be a very shallow defect here. And you can see also that this bone is very vital. It has lots of blood, so I know this is a very healthy bone cells. And you can see in the top picture here how the bone look like after being harvested from that area. So another also thing that I use a lot now these days, I use a kind of a technique that's been introduced into the market. And instead of cutting the bone and throwing it away in the suction, I try to move the bone at the site. And This is being created by a theory that created by a colleague, Dr. Salah Hawass from US, and you can see that he created this idea of osteodensification, and this osteodensification actually theory came by, if we rotate the normal drills in a normal way, which is a forward, you cutting the bone and you releasing, removing the bone from the side. So he came up with the idea, what if we reverse the drill and make it go on a reverse mode? See, once you reverse the drill, what the drill is doing, you can see it's compacting the bone at the side here. And you see it created this kind of compacted bone, and this drills can be only used in a cancellous bone. So if you have a soft bone and you want to increase the texture of the bone, you can reverse the drill and use this osteodensification drill that can compact. You can see here at the side how the bone became very compacted. And instead of having a very thin brittle bone, you can have a compacted bone, and then you can place your implant in a nice rigid bone, as you can see here. And then to understand this, we have to know that these kind of drills can be used in type 2 or 3 or 4, because it can only be used at the site where you have a cancellous bone, as you can see here in this part. But first you have to drill through the cortical bone by normal drilling action, which is you run the drills forward. And once you pass the compact bone, you can reach the cancellous bone, and this when you can start doing the densification, because the densification can only be done in the soft bone, which is cancellous, cannot be done in the cortical bone because the cortical bone doesn't have any gaps. So if you use it in this bone, it will not have any kind of benefit. So this is something very important. So I'm going to show you just a small video to show you that how when you have a very thin bone, if you use a normal drill, you will shatter all the bone and you will lose all the bone. You see the bone here is a very thin ridge, and I use the densification bar, as you can see. So I didn't waste any bone, I just compacted the bone. And then you can see the bone all at the sides. And then the implant is placed in a total native bone of the patient. And then you can graft the sides to increase the thickness. But this to show you that with this kind of drills, if I use a normal drill that I use it every day with every drill kit, that it will shatter the bone at the area, and it will just let all the bone get absorbed in the suction, and I will lose all the bone at the site. So this is a kind of technique that I use a lot now. I usually use it in every case. Just reverse the bear. This is how the bears look like. There are special bears, not a normal bear that you get in the drills with the kit, surgical kit that you get with the implant. They are designed in a way that they are not very aggressive, and also they are very important for sinus lifting. Actually, they are very good because they don't cut the membrane, that Schedene membrane in the lining the sinus, and they are very soft on compacting the bone. So this is the effect that you get when you're using this kind of drills. This is an image that was sent me by a colleague, Dr. Samuel from Russia, and he's comparing in the picture here the shape of the osteotomy site if you use a normal drill and if you use a densifying drill. You can see the bone accumulating around the border. And with this one, you can see there is no bone, because all the bone when you use a normal drill goes into the suction and you just remove it from the site. And this is due to the design of the drills. So this is some cases that I use these densification bears, and you can see that usually I use them after extraction. We have a very thin ridge or a bone that is interceptal bone between the roots. And if I use a normal drill in all these cases, I'm gonna just shatter this bone and I'll have nothing to stabilize my implant. If you look at the cases, they're all created by these drills here. You can see that the side is very thin bone, and the thin bone was compressed by the osteodensification bears. And then you can see that all these sites, we didn't have to delay the implant placement, which is good for the patient. The patient would like to have lots of surgeries. So at the time of extraction, you can manipulate the site by using these densification bears, and then you can place your implant at the site and then graft around the implant, as you can see, and look at the healing just after 3 months. So this is how these bears look like when you place them into the bone. You can see the amount of bone they accumulating around the area, and they don't cut the bone. And the major thing, one major important point when you use these drills, that you have to have lots and lots of irrigation, because the technique of these drills, they actually what they do, they compress the collagen matrix that between the bone particles. So in order to do this, you need lots and lots of irrigation to make this matrix soft. And then you do the pumping action, as you can see here. So this is just to show you the different way of using this kind of bears. And now we're going to go into our clinical case to discuss these points that we discussing earlier and how we implement these points in the real case. This is a case that came to the clinic, a guy in his 40s. He had a bridge that fixed to the roots by a post core, and he was suffering that is from the looseness of this loosening of this bridge that usually come back and glue it. And he said that he'd been doing this for many years in many clinics. Whenever he traveled, he has to go back, and he even carrying with him his own cement kit that he re-cement the bridge every time it falls. And then when we started to do evaluation of the case and examine, we can see that the teeth all are totally destroyed. As you can see, there is no enough structure to build a proper post core and a crown on this. So we decided to investigate the site to see, and we came to know that some of these roots are totally mobile because of periodontal problem. So we decided to extract them, and we do a very gentle extraction. We don't use any kind of pressure or trauma to the side, because I need to take them out very gently. And actually these roots were removed by just the forceps without any kind of pressure, because they were totally mobile, because there was no bone completely. You will see later on. And then we graft the site here. So sorry, we flapped the site here. And after flapping the site, you can see that we have a big amount of bone loss on the buccal side, total loss of the bone buccally in these two teeth here. And also on the other side here, we have dehiscence. We remove the roots. As you can see that everything was done in a very gentle way. We preserve this bone bridge here, because every piece of bone that we have at the side, we want to keep it and maintain it. You see the site is all cleaned well. Everything was decontaminated, and we remove all the granulation tissue and make sure that the site is totally clean, because I need to treat the site. It has to be totally clean without any kind of infected tissue. And we can see that we have a root here, and this root here, we need to do something about it, because I don't want to extract it and lose the bone around in that area here. So our treatment plan, that we will have 2 implants placed, one in the lateral area and one in the other lateral area. And then we're going to do a 4-unit bridge. So after agreeing with the patient on this treatment plan, this is what we decided to do. And we have to make sure that this area all restored in a nice way. And if you look at the occlusal view here, you can see that this view have a big defect. So I'm going to create my sticky bone here. As you can see, this is a magnified picture of the bone particles, and you can see the vital bone cells like this one here, and some of them at the back also is all mixed together. And this is the type of bone that particles that I use. And these bone particles, you can see that they are not too small, because if they are too small and you compact them together, they will not have a space for the blood vessel to penetrate through them. We need these only particles as a scaffold, so they should allow a space, and we should give support to the vital bone cells that embedded between them, and also they will allow the blood vessel to go through them. So you need these particles that will have lots of holes, as you can see here. the holes all over the particles, and the particles do not stick together in a way they create space between them. And this will help the blood vessels to penetrate through them. This is something very important when you do a bone graft and use this kind of a bovine bone. You have to understand this. So now I have to create a space. So I use this kind of a barrier because you remember this area didn't have any buccal wall, and we have here the ridge of bone that will support that area. And we decided to submerge this tooth here because I don't want to extract it, and you can see that if I extract it, I'm going to lose this buccal bone here. So I decided to submerge the root, leave it in space, and just cut it under the bone level, make sure it's not above the bone level, and then I'll proceed with this case. And then if you look at the case here from the occlusal view, you can see that the root is already submerged in a level that's lower than the bone ridge around it. And then I create the buccal wall here because I want to place my graft at this site. If I don't have this, the soft tissue will go into the site here, and it will invade the site. I will not have anything. And we rely here now on this ridge of bone to hold the tissue to maintain the space for this area to grow. So now we have to fill this defect with the bone particles that we collected from the patient. Also mix it with the bovine bone, and everything is placed at the site. You see fill the site, and you can see the gaps between the area, and you can see it's full of blood. So I understand that this area will be very well vascularized. Also look at the site here. We have enough amount of blood vessels coming to the site, and the both area will be filled with a sticky bone, and then everything will be covered, and then we'll see how it looks like. So what we cover this area with, after placing the bone particles, we cover with first thing the collagen membrane. As you can see here, this is a collagen membrane, and this is also a collagen membrane here. And then after the collagen membrane, we put another layer of PRF membranes, as you can see, and then everything is sutured. And if you look at the suture here, we have two kind of suture. I did them in two different colors to make you understand. I have a stabilizing suture here, as you can see, this is in white, and then we have the closing suture, which you can see them in black. This is just done for the intention of education. You can see that these white sutures are the horizontal matrix suture that I use to stabilize the flap, so the flap doesn't open with the muscle movement. And then these interrupted suture here with the black color, they just to close the incision line. And in that way, I make sure that everything is closed nicely. One more important thing that you can see that I always have this little kind of space in my sutures. I don't tie the suture too much because you have to allow the soft tissue, because the soft tissue will have some kind of swelling and edema after the time of the bone graft. So what we usually do, we don't tie the suture a lot. We don't make it very like tight, because if you tie the suture a lot to the flap, you're going to end up having a kind of cuts in the flap when the area swells up a bit. So we leave this kind of spaces in the sutures. We don't knot it too close to the soft tissue to allow the expansion of soft tissue to happen. And all these sutures function is to approximate the incision lines. We don't want them to touch the soft tissue in a hard way, that if the tissue swells up, it will start having a kind of cuts, and you will end up having a wound opening at the site. So this is the stabilized suture and the closer suture. As you can see, we come back to the site just after a few months, and you can see how much bone that we have. Look at the bone, all vital and bleeding. And I understand this bone is a true bone. It's not an artificial material. It's a true vital bone. You can see the bleeding, amount of blood vessels vascularizing in the area, and you can see all the bone cells already in a bleeding way. So we understand that this is a vital bone cells. If I come to this site without knowing that I grafted this site, I would think this is just a vital bone, that this site was not grafted before. And this is the beauty of having a mixture of vital bone cells at the site. If you look at the occlusal view, I want to compare this view here because it's a very important, just to prove to you something, that once you create more space, you see here we used the titanium mesh look how much space we created. And the space that we created allowed the bone to grow more. This side here, we relied on the root submerged to support that area. And we had only this thin bony ridge was here at the top. So because we didn't have a longer distance for the bone to grow, and we had only this limited area, which is related to the bony ridge and the submerged root, the bone just grow to that space only. But you see the area where you created a bigger space by placing a titanium mesh on the buccal side. The bone had a more bigger space, and every time the bone will have a space, will grow into that space. So this is the importance of having a space when you do a bone graft. This is just to make you understand what the meaning of creating a space at the site. And then everything healed well, as you can see. If you compare it before and after, look at the amount of bone growth in like in the top picture here after healing, and this is the picture just at the start of the surgery. Now we have to consider our area to be suitable enough for placing our implant. We want to place 2 lateral here in this area, and we have enough bone to do this. So again, I use the osteodensification burrs because this site is a soft bone that we just grafted. So I don't want to use a normal drill that shatter the bone out and take the bone that I grafted, because this bone, we start doing it from nothing, and we want to create enough thick bone. So we created this bone, and I did not use a drill that I can just take out the bone that I've been growing in that site for 4 months. So what I usually do, I use these densifying burrs because they will just compact the bone to the side and make the side more durable for stabilizing the implant at the site. So the 2 implant is placed. You can see the amount of blood coming to the side. So I understand that this is a real vital bone. And also I can see that I have enough bone on the buccal side on each side of the implant, so I don't need to regraft again. So the area has adequate amount of bone that I can just proceed with my case. So this is after placing the 2 implant using the osteodensification burrs, and we switch everything, leave everything to heal. And this is just few months after healing, like 2.5 months after healing. We see that everything healed very nice, but I didn't like this kind of defect here and here. This is a defect that we can manage it when we do the second stage of the exposure. And this is how I manage the site. I take the soft tissue from the palatal side, and then we do half thickness flap just to peel this soft tissue keratinized and move it to the buccal side of the implant. You see here 2 areas were done in the same way. And again, we suture everything, and you can see that there is no tissue on that side where we took the graft. So what we do, we just leave it here because this graft is pedicle graft. It's not totally, it's not a free gingival graft. It's just a apically positioned flap, and you can see that this soft tissue will grow into that direction to fill the gap. So you leave it exposed like this is not a problem, and you just leave it exposed. And in that time, we place our gingival former, as you can see, and leave everything to heal, and we come back. This is after just nearly 1 month of healing. You can see how much soft tissue we have on the buccal side here and here. And if you compare the picture before we start, and then after placing the gingival former and do the soft tissue management, look at the amount of soft tissue, concavity now, and now convexity at the end. And you see that this defect here and here, we create the bulge, a big amount of soft tissue bulging in that area that will create enough support to the implant side, because I have enough keratinized soft tissue in a vertical and horizontal direction. So I know that my implant will be protected for a long time, because we all understand if we don't have enough keratinized seal around the neck of the implant, this will lead to pre-implantitis. So now we come back to the case to take an impression. You see that I'm using a closed tray technique because the 2 implant placed in a parallel direction. I know that I want to have a screw retained final prosthesis. So I have this kind of position, because I usually do like a suck down tray or like a bleaching tray that I place at the time of placing the implant insertion, just to know where is the final crown going to be. So I place my implant in a direction that I'm going to have a screw retained implant, screw retained, sorry, bridge at the end. And that's why the direction of the implant coming into that side. And then everything is placed. I check my implant stability, the ISQ. You can see the reading. It's at least it's a very, very high reading. It's a 74 ISQ reading, which is a very high. I understand that this implant is ready for loading, and the site is very well stabilized by this soft tissue. Look at the amount of the keratinization around the area here. So I know the area is ready. We start now manufacturing our final prosthesis, and this is a 4-unit bridge that created by our lab technician, and you can see the screw holes coming to the palatal direction as I planned at the beginning. So this is something that we always do, plan the case with a wax up, and do a suck down tray on the wax up and place it in the patient mouth. Make sure that we want to have a screw retained crown. So the direction of my implant will always be at the right direction, so I can support it by a screw retained final restoration. And now everything is sealed with a composite, as you can see, and you can see little cuts here. I do always little cuts at the palatal side, and these cuts, you can see this bleeding, maybe you can see them here more than the side here. What usually do with this, we profile the emerging profile of the case on the cast, and then build the crown on it. And then when I place the crown at the side, I do a small incision here and in the palatal side, just to expand the soft tissue. So once I place my bridge and crown and I screw it in, it will push the tissue to shape the emerging profile that I want it to be. And you just leave it to mature, and takes time to mature. And this is how the case started at the beginning, and then this is how we finish it. And if you look at the occlusal, the buccal view, see the patient have lots of discoloration, so we mimic the coloration here. Look at the amounts of tissue we have here on the buccal side, a big amount of soft tissue, and everything looks nice and stable. This is the time of insertion, and if you leave this to mature for a few weeks, you will see lots of soft tissue cooling down, because we have a thick soft tissue that we created here. And then this is how the patient smile at the end of the treatment. So if you see that case was taken from a very big defect to established with a bone graft first, and then the soft tissue management came after that, and then the implant was placed in a correct direction, that you can place your final restoration as screw retained, and then you can place your final restoration in a good way that will be supported by enough amount of keratinized tissue. So I know that my implant will be protected from any bacterial invasion, because I have enough of tissue collar around the implant neck. So I know that the implant will be in a good kind of successful position for many years. I'm gonna show you another case here, that just a small video about the same thing as well, just quickly to summarize all what we did together. You can see it in a case quickly in a video, just to show you how the case starts. With this video, I'd like to thank you very much. We came to our end of our presentation. This is my group on Facebook. You're welcome to join this group and post your cases and discuss any complication that you have or any kind of idea that you want to get. And also my Instagram page and Facebook, if you like to discuss with me or ask any questions, you're welcome to send me any message. I will get back to you as soon as I get the message. Thank you, Omid.
Thank you so much for your very beautiful, comprehensive presentation, full of beautiful cases. And actually, you covered almost all techniques in guided bone regeneration, speaking of membranes, speaking of titanium meshes, and you know, sticky bone, and you covered almost all aspects. So Ehab, I have a couple of questions and comments regarding different techniques. First of all, I want to know, actually you mentioned that, but I want to know when you face a case that needs bone reconstruction, you see the bone is not that thick. So what is your criteria to decide to place your implant and do the graft at the same time or go with the stage approach? Because I noticed that in most of your cases, you prefer to do it at the same time, place an implant and do the reconstruction, if possible. So I want to know, what is your main criteria?
Well, you know, well, nowadays everyone wants to be very conservative. So my main target is, if I place the implant in a correct position, if I see that the implant can be placed in a correct position at the time of the surgery, I do this. You see the case that it had the big defects. I couldn't place the implant in the correct position at that time, so I had to delay the implant placement. But in any case that I see that the implant will be placed in a good 3D direction and the position is good, I can place the implant. Also, if I can see that I can create enough stability, if an implant will be stable enough, if I have enough bone to anchor the implant well and stable, I can place it. I only delay it if I don't have enough bone to have good stability with the implant, or the bone that I have available at the site will not give me the right direction of my implant, because I always aim to have a screw retained crown. You see, most of the cases, all the cases show you the all screw retained crowns. So my main decision is the position. If I can get the implant positioned in a good way that I have a final screw retained crown, I can do this. The second thing, if I can anchor the implant in a way that I get a good stability. This is the two parameters that I always look at when I do an implant surgery. So if I don't have one of them, I delay the case to a stage case.
Oh, I got it. And speaking of titanium meshes, those that you're actually very famous of it, because you have tons of cases of those titanium meshes on the implant. So I want to know if you fix the apical part of the mesh also in GBR cases, that you fix it on top of the implant. I want to know if you fix the apical part of the mesh too.
Actually, with this, there is different kind of mesh. This mesh, the one I fixed to the implant, it's a pre-curved mesh already, so it has a very kind of rigid curvature that it does not deform. The mesh itself is a rigid mesh, So once you screw it onto the cover screw or in the implant, it's very stable. It's not moving. It's very important to have it very stable. It shouldn't be, moving or shaken at the side. If you see the big case that I used, I placed the screw at the apical part of the mesh, because this mesh is different from the one I used on the implant. This mesh is more soft and it's more bendable. The other one is quite hard. You cannot bend it easy. It's very stiff. So you have to understand also what kind of mesh you use. If you use a soft mesh that can be bent and turned, you have to stabilize it more at the apical side, because if the patient move the gum and touch the area, it can cut the soft tissue. But if you have this one it has a polished end. It's a very rigid. So once you place it on the neck of the implant, it's sitting on the bone with the pressure. Yeah. It's not soft and moving. The other one, because it's more like a bendable mesh, I screw it at the apical area. See, I could not screw it at the coronal area because I didn't have enough bone to hold it. But that's why I placed the two membrane on the top at the ridge, because I don't want this area to be in direct contact with the gum and leads to like dehiscence at the area. And that's why I have to understand also not every titanium mesh treated in the same way. You have to understand it's a rigid or soft. If it's soft, you have to stabilize it more. You have to put more screws. If it's a rigid mesh, you can also just connect it to the neck of the implant, and the rigidity will make it push against the bone, so you don't need to screw it. Because the purpose of screwing the mesh is to stabilize it. It has to be stable. If it's shaking or moving, it will cut the soft tissue. You will have an area with instability in the healing and can lead to a complication. This is something that many people don't understand, that they use titanium mesh in the same way for every kind of mesh. Every mesh has its character. You have to understand if you're using a soft one, if it's hard, if it's bendable, or it's rigid. Because some meshes you just need to put them, we can put them with one screw. And other, you can put many screws in every corner because it's bendable and it's very soft.
Yeah, you're right, absolutely. And Ehab, do you prefer to put membrane on top of the mesh to reduce the risk of exposure? Do you believe in that or no?
Yeah, of course, yeah, because I always want to have like a buffer area between the soft tissue and the mesh. Even if the soft tissue thick or thin, I still, just to be on the safe side, cover with a collagen membrane and cover with a PRF, just to make sure that I have all the protection from the mesh on the soft tissue, so it doesn't have a direct contact. Yeah. I used to avoid this at the beginning when I see thick tissue, but sometimes even with the thick tissue, the patient start touching and pushing the area, because all our patients want to feel and see what happens if you touch the area. So if they push the soft tissue with the finger against the mesh, it can cause like the soft tissue to be snapped or cut, and that can lead to complications. So that's why I like to always have something to cover the mesh, not to be in direct contact with the soft tissue. I'd rather take all the precautions rather than just be adventurous and then have a complication and then start thinking how to solve the complication.
And Ehab, my last question actually mentioned that, but I wanted to highlight the point at the end that in those beautiful cases that you do bone reconstructions, massive cases that you showed, even the small ones, what is your main preference of the bone graft material that you use? If you want to name your first priority in choosing the material or any mixture, what would it be?
Well, as you see in the first few slides of the lecture, I was talking about osteoinduction and osteoconduction. When you have a graft at the site, you need some stimulation of the bone cells, because the bone cells don't understand that we are a dentist. We want them to grow at this direction or in this area. So what we have to do, we have to create a field that will allow these bone cells to grow at the site. It's like having a plant. When you have a plant, you can put threads for the plant to crawl in these threads. The same thing, if you have a defect at the site, you need to have some vital bone cells to start growing in this site, and then you use this kind of mix of bovine bone or allograft or something just to support the cells. So you will guide the cells to grow into that direction, because the cells don't understand that you want to have growth in the buccal direction or apical direction. The cells don't understand this. They don't understand the mesial distal direction, buccal direction. They understand that if you have a nice surrounding or field, it will grow into that field. So what we try to do, we try to create a field for the bone cells to grow. So usually I put vital bone cells, and everyone tell me how much, what's the ratio, 50, 60, 20, 30. I really don't care about these ratios. I want to make sure that I have enough vital cells. If it comes with your common sense, you see a big defect, so you need biologic lots of bone cells. You see a small defect, you will need less cells. So I try to put enough cells and support these cells with the bovine bone or even cortical cancellous bone that you can take it from a bank, and I just place it. And for brands, I really don't care about brands. I don't even know what brands I'm using in the clinic. I ask my assistant to buy. I tell her I need the bovine bone, I need the allograft. I don't care what brand, what company is doing this, because brand and companies doesn't matter. It's only what's inside this material that you use. If I use an area that I don't get enough bone from the patient, I will use more allograft. Like, because some patients reject to have another donor site to take bone cells. In this case, I will use an allograft. If a patient accepts to take an site from another site, bone particles from like a retromolar area, I will take this vital bone from the patient, mix it with a bovine bone. I will not use allograft. So you have to understand the material, what the material actually is doing. And for the material to be doing something, you have to place it at the right condition to get the effect of the material. If you have a big defect that you just place a bovine bone, this bovine is just non-vital cells. The bone cells surrounding the defect will not understand that you want them to grow into that direction of the bovine bone. So you have to have a stimulation. So you put natural cells at the site. These cells will crawl around on the this xenograft, because we that's why we call it scaffold. If you look at the building sites, you see the building is all constructed, and then you have these scaffold outside for the labor to move around the building on the scaffold. If we take these builders as the bone cells, these bone cells will need the scaffold to grow around, to move around, to reach in every direction. And that's why you have to understand what the use of the material and what the characteristics of the material, what this material is doing. You cannot just expect to put a bovine bone without any vital bone cells, and you think when I come back, there will be vital bone. Okay, you might have a fibrous tissue that have lots of xenograft particles. That's why sometimes when you look at the grafted site, you see lots of white particles, because he placed the site with a xenograft, and all the matrix around it is full. It's all fibrous tissue. It's okay. It's not really real bone. You see the case that I show you at the end. When I remove the mesh, when I open the area, it looks like this is a patient bone, because I use very little amount of xenograft just to scaffold the vital bone cells, and I put plenty of vital bone cells. And this is the understanding the characteristics and the property of the material that you use. And many colleagues ask me, what kind of bone graft do you use? Which bone graft do you like? It's not, I'm not going to a restaurant to like something, put some topping. You have to understand this material is used for what indication and what do you want to achieve. Based on your target of achievement, you want to choose the material to use. And this is something important, that you have to understand each material. What does it have inside? What's the effect of this material on the cells around the area? If you put this material with the vital cells, what the cells will do? they will use it to grow, they will use it to just to use it as a scaffold. Uh, that's why you always, I advise, like especially young dentists, to read about this material, what every material is doing and what's the function of every material. It's not a matter of, okay, every defect, I'll use the same technique. It's not like this. You have to understand the size of the defect, the nature of the defect. If you place an implant, or if you don't place an implant. If you place an implant, you have to have some vital cells in direct contact with the implant, and these cells will need nutrition. You need blood to come to the site. So you make sure that these cells, if you just leave them on the implant is a metal structure, is not vital, and these vital cells will be sitting there. They need to have oxygen. They need to have blood. If you just leave them without this blood supply and oxygen, they will die. So you have to understand why you're using this material in what situation. And every situation have a different treatment. It's the understanding of the histology and the physiology of the bone, and the bone, how the bone grow, how the cells in the bone grow. If you understand this, it's exactly like doing a cavity preparation. You want to remove all the caries. You want to make sure that if you reach the pulp, you have to do pulp capping. So you understand the effect of the treatment on the structure and the tissue. Based on this, you'll make a decision. If you're doing a cavity preparation and you reach the pulp, you know that you have to do a root canal. You don't reach the pulp and you think, okay, I want to do a filling, let me put a filling. You change your protocol based on the situation at the site.
Yeah, you're right. Actually, that was a main point that I wanted to highlight by you, because it's they're all materials. The important point is that we should know what to choose and when to choose, with what purpose. Ehab, I truly want to thank you for your time, for your support, that you accepted the invitation to join me this year also. And because of the situation, it happened to be virtual this year, but I want to thank you as always for your support, for your amazing presentation, for your time, and hope to see you very soon. And with that said, I want to say just thank you and stay safe. Have a great time.
Thank you. You too. Thank you very much. Bye-bye.